those affected by mitochondrial disorders, UMDF is here for you. Since 1996, we've worked to provide support, fund research, and create awareness.
Our mission is to promote research for cures and treatments of these diseases and to give support to affected families.
We want future generations to grow up in a world without mitochondrial disease.
I'm playing for the United Mitochondrial Disease Foundation.
Look at that. Nice check for you.
Over the years, our community has grown and our message has sparked a movement.
Hey everybody, it's Maya Mialik. Have you ever heard of mitochondrial disease?
Together, we've been able to make a difference for patient families around the world. Today, we are helping thousands of people navigate their mitochondrial disease journey. We're here, listening and providing support. We're here, educating and connecting patients and healthcare providers. We're here, finding and funding the best cutting-edge research. We will not rest until we find a cure. Join the movement at umdf.org.
Hello, everyone. Thanks for joining us for our latest Ask the Mito Doc webcast. Tonight's topic is medical billing, and we will have presentations from our panelists, and I'd like to introduce you to this great panel tonight. First, Michael Friedberg is not only an expert on this subject, but he's also the father of Zachary, who has mitochondrial disease, and with more than 20 years expertise in healthcare management, he'll be able to answer your questions from a parent's perspective. Michael will be joining us from New Jersey. And joining us from the greater Philadelphia area this evening are Dr. Amy Goldstein, who is an attending physician with the Division of Human Genetics at the Children's Hospital of Philadelphia, CHOP. Of course, one of her specialties is mitochondrial disease. And also joining from CHOP is Colleen Marescu, who is a certified genetic counselor and program director of the Mitochondrial Medicine Clinic. Now, before we hear from our panel, we do have some housekeeping items for you. We have muted the lines, so if during this webcast you have any questions that you need to ask, please use the Q&A button to type that in. And once you type your question in, we'll proceed to get you some answers. We also ask that you keep your questions focused on the topic of this webcast. We really can't take questions that aren't connected to tonight's topic of medical billing. Also, please note the information about the closed caption service and how to turn that off if you do not want to see it during this webcast. Our Ask the Mito Doc webcasts are made possible through the generosity of these sponsors, so we ask that you join us in thanking them for their support. Also, 2021 is UMDF's silver anniversary, and throughout the year we will have special memories on our website and on our social media channels, so stay tuned for that. We also want to tell you about updates made to our coronavirus website page, our resource page, specifically about the upcoming distribution of the vaccines and its impact on our patient community. So make sure you check this out, and there's some great information there, and we hope that you will visit there often. Also, make sure you check out MitoU. This is a great resource for our patient families and for our scientific and medical community. MitoU provides you with helpful information on diagnosis, treatments, and it will be continually updated with informational videos for your viewing, including these archives of the previous Ask the Mito Doc webcasts. As you might expect, out of an abundance of caution for our patient families, scientists, and clinicians, Mitochondrial Medicine 2021 will be virtual again this year. We will begin on June 24th and end on June 26th. And we invite you to check out the UMDF Symposium webpage for updates, schedules, and registration information. And registration will be opening this week. We also want to let you know about another important program UMDF has provided for 25 years, and that's patient support. We can connect you to one of our 90+ ambassadors around the country, or to one of the hundreds of support meetings we hold throughout the year on a monthly basis. So please reach out to us if you need support. You can contact us at 888-900-6486. And our Energy for Life Walk Your Way walkathons are getting underway this spring, but we're doing it safely. You can find a walk location near you and walk your way at energyforlifewalk.org. Now, looking ahead, next month, Interesting topic. Our topic for Ask the Mito Doc in April, actually just a few weeks away from tonight, will be siblings and mitochondrial disease. So mark your calendars for April 7th. We'll begin at 7:30 East. And watch your email and social media for ways to register and to submit your questions. So let's get started with this edition of Ask the Mito Doc. Panel, thank you for your generosity of time tonight. And first, we will turn things over to Mr. Friedberg.
Okay. Now, if I can just do this correctly. Okay. Here's my, oops, let me put my, okay. All right. Everybody see that? Great. So good evening. I'm Michael Friedberg, and I'm going to talk to you a little bit about billing and what to do for your mitochondrial disease care. You can see that I work for a company called Parallon. Parallon is actually a subsidiary of HCA Healthcare. So for those of you around the country, your local hospital may be an HCA facility, closest facility. And I work in their outsourced billing area operations for non-HCA hospitals. And I started my career working in an academic medical center in New York. And I worked for a very famous physician scientist who was a pioneer of gene therapy. And I learned all about academic medicine, medical research, FDA, drug applications, NIH granting. And little did I know that all of those things and all that information would come in handy because I have a child who is affected with mitochondrial disease. So just a little bit more about me. As Cliff said, I have been working in healthcare for 25 plus years. Last 15 plus years focused on what we call revenue cycle, which is the process of hospitals and doctors getting paid. And Zachary is my son, as Cliff said. Below you can see we've been involved with UMDF for 20 years coming up on this year, since 2001. And I've actually been a trustee since 2017. And on the left here, you can see Zachary when he was little in the first two pictures. In the middle there, in the black sweatshirt, that's him recently. He's 23 years old. And that's my other two children with him on the right-hand side. So I'm definitely looking forward to the next discussion about Mito and siblings. And I have expertise in healthcare billing, which is why I was asked to join today's presentation. So let's get into it. And I want to just state from the beginning that medical billing is really complex and complicated. I've been doing it for 20 odd years, and there are still things that I don't know, or I learn, or I have to look up, or I have to use everybody's favorite tool, which is Google. And so I bet in answer to the first couple of bullets here, I bet a lot of you say to yourselves, why do I get so many different bills from so many different people and places from the same service where I only went to one place and I was only there for a couple of hours or a day or a couple of days? It's the complication and different ways that billing has to be done that end up causing these additional bills to be produced. And so what I wanted to do here was, before I get into tips and tricks and things that I think you ought to do and know about, I wanted to give you just some foundational items that help explain the process a little bit. And as I said, it's not only complicated, it's ever-changing and highly, highly regulated by both the federal government, states, and in some instances, even local municipalities, depending on what topic we're talking about. So the first set of bullets tells you about the different types of bills that you can get. So there is a hospital bill, which is what we call the technical part of the bill. this is the cost of the room, the supplies, the nurses, housekeepers, keeping the lights on, and the technology, and everything else that goes into running a healthcare facility. The physician bill is the professional part of the bill and compensates the licensed practitioners for their time and skill. Think about doctors, physician assistants, nurse practitioners, therapists, social workers. Those that are licensed can bill. By the way, the hospital bill we call Part A, and the physician bill we call Part B. That is the Medicare terminology. And so when you talk to people, if they refer to Part A and Part B, now you know what it is they're talking about. And so the billing gets definitely complex depending on the setting in which you see your provider, but keeping it to Part A and Part B is a good start, because everything, for the most part, fits into either technical or professional. So now let's talk about the different types of insurance you have. So we're all familiar with governmental payers, which are Medicare and Medicaid. I'll talk more about Medicaid in a few minutes. Then there's commercial insurance and third-party liability, which is generally workers' compensation, you get hurt on the job, or motor vehicle accidents. That generally does not apply in mitochondrial disease. Matter of fact, I can't think of an instance where it would. And then within governmental payers, you've got managed Medicare and managed Medicaid, better known as HMOs. Same with commercial insurance. There are all kinds of different. There's government-sponsored, there's employer-sponsored, there's groups that have it, there's union plans, there's all kinds of different insurance. And one of the tips that I'll give you is you need to understand your coverage, especially if you have somebody who has a chronic medical problem. And this comes along with understanding your rights. So two other things that I wanted to make sure, and I could spend an hour talking about the types of bills and the types of insurance, but I'm not going to do that for time purposes on this call. So it's also worth noting that, as I said, healthcare has tons of rules and regulations, some federal, some state, some local, and sometimes they even contradict each other, which is really a lot of fun. This means that payment, coverage, and other items are somewhat state dependent, and what is paid for in one state may or not be paid for in another state. So comparing yourself to others who you talk to in the mito community in different states is difficult. So if you're in California and you talk to somebody here in New Jersey, and you both have Medicaid coverage for your affected family member, what's actually covered and not covered, and how the coverage is, oh my God, I'm losing my words. How the coverage is implemented may be different. I also wanted to talk for just a minute about surprise billing, which is something that you might have heard in the news lately, and it's starting to come to the forefront. And so the example of this is really pretty simple and basic to break it down. And this is generally how it works. You go to a hospital and you have a surgery. You do your homework, you know the surgeon and the hospital are in network for your provider. But then after the surgery is over, you get your bill from the anesthesiologist, and you find out that the anesthesiologist is out of network, and you get a humongous bill from the anesthesiologist. The government, both federal and states, are trying to prevent this type of billing.
And then the last thing that I wanted to mention is charges are not an indication of reimbursement. So on your bill, and we're going to go through that in a minute, I'm going to talk about it in a minute, you will see charges. And so typically charges, reimbursement is 30 to 35% of charges. This means for $100 of charge, the provider typically receives somewhere between $30 and $35. So when you see a hospital for $100,000, that doesn't mean that's what the hospital actually gets. Okay, so here's an explanation of benefits. It happens to be for a service that I had. So you can see there, amount billed. This is the charges that I talked about on the last slide. Then you'll see member rate or allowed amount, depending on what your EOB looks like. That's the amount that the insurance company will typically pay. You can see in this instance, the percentage is about 16% of the charge. And these are all pre-negotiated rates between the insurance companies and hospitals and physician networks. Then you'll see here there's some that's pending or not payable. There are a number of reasons, but this you need to check and be careful about for items that are not paid or pended. Sometimes something will be not paid or pended due to a lack of authorization. So you need to know your coverage, and you need to know what requires authorization and what doesn't. Typically, providers will tell you and will obtain authorization for you in advance of a procedure, but it's always good to know and check. And then deductible is the set amount you pay before the insurance kicks in. And this can't be waived by your provider or negotiated. That's one piece that cannot be waived or negotiated. And then coinsurance is a percentage you agree to pay. So in this instance, I pay, I think, 20% of bills up to a certain maximum. Okay. Okay. So what should you do? What are the tips and tricks? What are the things that will help you? Know your coverage and know your rights. Varies from state to state. Stay organized. So long ago and far away, when we didn't have the cloud and scanners and all this fancy stuff we have now, and you can take a picture with your phone and save it in the cloud for eternity. I used to have a notebook, and in the notebook, it would have the visit, and then there would be a new tab, and I'd have the explanation of benefits. EOB, that's what I showed you on the last page. And we would track what got paid, what didn't get paid, what did we still owe, what didn't we owe, what was covered, what wasn't covered. So that's staying organized. And you can do the same thing with folders and so forth on your computer. So when you scan stuff, make a folder, Children's Hospital of Philadelphia, make a folder for each physician, make a folder for tests, et cetera, et cetera. Keep yourself organized. And make sure you get an explanation of benefits and compare it when you get a bill from your provider. Next thing, generalization, but I think it's important to say, if you have Medicaid, you should almost never pay out of pocket. In my example, I have traditional employer-sponsored insurance, and Zachary, who has Medicaid as a secondary insurance. The Medicaid picks up what my Aetna doesn't pay. And again, since he got Medicaid at age 18, we have not paid an out-of-pocket bill. Now, we'll talk about uncovered stuff, Mito cocktail, those kinds of things in the Q&A later, because there's a question about it. But again, rule of thumb, okay? Second, if you have a bill from a provider, I'm sorry, one other note. In terms of employer-sponsored insurance, if you have a disabled adult child, they can stay on your policy forever. Caveat to it. If they drop off before they're 26 or at any time after they're 26 and then want to come back on, you can't add them back. So you don't have to worry when they turn 26 that they're going to drop off your insurance and have only Medicaid. They will have, that was part of the ACA, Affordable Care Act, also known as Obamacare. And again, you can Google it. I'm talking in generalities. You always want to know your rights. So what happens if you have a bill and you don't know what to do or you can't pay it? Or your insurance company won't pay, or any of those scenarios? What I suggest is most of us get our care in one place. Generally our local hospital or a certain number of providers and doctors. Call the hospital or provider's office, ask to speak with the revenue cycle department. Smaller offices may just have the office manager do it. Make a friend. Ask to speak to a supervisor or a manager. And again, just tell them, I have a chronically ill child. We're coming a lot. I don't know. I don't understand this. Please help me to make sure my bills get paid. And don't forget, physician bills and hospital bills are likely separate. So you'll be calling two different departments. We're starting in the industry to consolidate them, but right now you're going to find a lot of separation. Ask for a discount. Hospitals will give you a discount on your patient responsibility portion. Ask for a payment plan. Most will allow you to pay it out over 24 months without interest. So whack it into 24 payments if you can. Apply for everything you're eligible for. All hospitals have charity care programs. Some states have charity programs. There are sick children funds that some states have. And again, they have limited funding and it's first come, first serve, but I would ask for everyone and everything in order to get you the help you need in order to get your bill paid. And don't get mad when you find a mistake. Just communicate. These bills are super complicated. There are hundreds of elements that go on a bill. And if one element is even slightly off, the provider won't get paid from the insurance company. They're just as mad as you are. They want to get paid. So don't get mad. Just communicate and talk to them. What are we doing to fix it? Okay, final thoughts. Don't panic. No one is taking away your house because you can't afford to pay your bill. As a matter of fact, most of my clients have stopped taking legal action, and it's just getting restarted now. They stopped because of COVID, and the courts are going to be backed up for years. And when I say no one is taking your house away, what I mean by that is hospitals generally don't like the negative publicity of big bad hospital takes away little old lady or disabled child's house just to pay their bill. They used to do it. They got very bad press for it. And so, again, rule of thumb. However, if you have means, you have a job, you have assets, you own a home, they will expect some payment. But if you work with them, there's always a way to work it out. Okay, and then last part of this, and again, most people in the healthcare billing office, they want to help you. That's why they do the job. They're there to help other people. And again, generalization, and anyone can have a bad day. And so always you can speak to a supervisor. And then the last point I wanted to make before I stop is, I'm sure Dr. Goldstein and Colleen will appreciate me saying that your doctor, especially in academic hospitals or large practices, generally don't get involved in billing. So you don't have to worry about your continuation of care if you don't pay the bills. Some very rare exceptions to that, again, as long as you're working with them. Or you don't have to worry about going to an office visit and the practitioner looking at you at the beginning of the visit and saying, you know what, you didn't pay your $25 copay from last time. So, you know, you're going to have to pay it in order for us to have that visit. It just doesn't work that way. And you shouldn't feel uncomfortable about it. And again, in most instances, the physician is fairly removed from billing operations and impact on billing. So again, communicate early and often is my mantra for this presentation. And with that, I'm going to stop and turn it back over to Cliff.
Thank you. And with that, Colleen and Dr. Goldstein, are you prepared to enlighten us on this important topic?
Yeah, I'm going to take the screen over. Sorry, a little slow to wake up. All right, so excellent. Thank you, Michael, for the great introduction. And, you know, just speaking on behalf of Dr. Goldstein and our team at CHOP, I will say we are just as frustrated and confused on patient billing as well. I think it's almost like learning another language, and it is compounded because you all are also dealing with complex medical problems. So you're now trying to figure out the medical language for all of these needs, and then you also have to learn the insurance language. So hopefully a few additional thoughts and tips from our side will give you some additional insight to help you all navigate this complex process. A few things how I think about this, is, as Michael said, a lot of you may be seeking care locally, which in a lot of instances, that's easier, right? It's in your state. You might have a state Medicaid. There's a lot of in-network benefits for you, meaning that you'll be less responsible financially to see those providers. But then what happens if you're in the middle of the country and you need to go to mito specialists all across the US or at a different center? That becomes much more complicated. And those providers can be out of network. And so I think of in-network is you might be responsible less financially, and out of network, there may be an increased cost to seek care there. But there are a lot of things that can be done. I will say very rarely, but we do have instances. There are patients that are coming from out of network where they flat out are not being able to be seen at the institution. Usually there are some additional steps that can be taken to help to get that appointment paid for and for you all to receive care. And so thinking about referrals, which that's a little different than needing a prior authorization. So a referral might come from your primary care doctor or the pediatrician, which is usually where it comes from. In Medicaid and Medicare's, it's mandated that it comes from those individuals, whereas commercial insurances might require, if it's your local neurologist referring you to a team, that they actually initiate that process. And then prior authorization, just as Michael was saying, is what it says is that an insurance will pay or agree to authorize a code, but it doesn't tell you at what cost or how much. And that's where you'll need to understand coinsurance and deductibles. And then there might even be additional approvals. So for example, at CHOP, I work a lot with our direct billing individuals that help with this process, but you might need an out-of-network prior authorization, and then the insurance and CHOP has to come to negotiation, and that's called a single case agreement. So they have to agree upon an amount that will be paid before a patient can step foot in the office. Like I said, this is frustrating for us on multiple levels, and we are, I say, improving the communication, and I know CHOP and other large institutions are really trying to help forward-facing to help families know this information up front, but it's still a work in progress. The other thing is, great, you can come for the appointment, but what if there's other things that the doctor recommends when you come there? Can you have labs drawn there? Sometimes, as Michael was saying, there's two different fees. There could be a lab draw fee, and then it's where they're actually sending the sample to. So some institutions can send it out through LabCorp and Quest. Others have to send it within their institution. So understanding if you're capitated or need to go to LabCorp or Quest, that's something important to communicate to your team. So when they're providing scripts, you can go to the lab that's going to be least cost effective. And sometimes too, there are specialty labs that need to be drawn, especially for our patients. And you can always ask, is there things that I can get done locally, and what maybe be most beneficial for me to get done there? The other thing are medications, like where should your prescriptions go? That's also dictated by insurance and your insurance plan. So do you have to go to CVS? Can you go to another pharmacy? Do you have a pharmacy locally? We worked with some great local pharmacies that really go head to head with insurances to fight for those prescriptions authorizations. We can't say enough about some compound pharmacies too. And I can't emphasize it enough. What Michael was saying is just understanding your insurance plan. And even before you pick it, we've had patients who've been in job transitions or moving from different states, and they wanted to make sure that they can keep their specialists at the institution. So for those individuals, they've called and say, if I pick X, Y, or Z plan, would this still be something that, would work with the institution? So all of that can be done and communicated ahead of time. And also making sure your insurance is up to date. I know that sounds simple enough, but bringing those insurance cards to your appointments to make sure they're actually getting billed. I can't tell you how much I've heard where the actual wrong insurance was billed because it was an old insurance in the account. Once again, with electronic records, this is improving. And then, the question always comes down to, can you have the testing? And, as Michael was saying, there's different types of bills. There's also different ways to bill, and that can get confusing too. So, for instance, in our institution at CHOP, we can only do institutional billing, whereas that essentially the bill is generated. So say if you had a test in, let's say, Hawaii, and then would get billed to the institution, and then the institution would generate the bill that would go to your insurance. So you're only receiving a bill from the institution, not from that testing company in Hawaii. Another way is that you could directly bill to insurance. And so that's a difference where you're having that test, say, done and performed in Hawaii, you would actually receive the bill directly from there, not through the institution. So the institution would be cut out entirely. Not every institution has that option, but we try as a clinical team to work the best that we can to mitigate some of these costs. Institutional billing is always going to be a little higher than direct to insurance billing because of different contracts. They have to kind of treat all patients the same. And then, of course, there's self-pay. And believe it or not, sometimes with deductibles and other co-insurances and things to think about, self-pay is sometimes a cheaper option, depending on what testing and things like that you need. And in the end, I think the key is communicating. We are a team, your clinical team, as well as your family. We, of course, don't want anyone to receive a $20,000 bill, and we're just as appalled with the cost of things sometimes, especially with simple lab testing. But, if there's another lab or hospital that you're aware of that's in network, or you heard of a lower cost, just talk with your clinical team. Sometimes that might be a viable option, and other times, based on methods or experience, your physician and team might say, that actually, sometimes, the lower the cost, the lower the product. It might not be the best way to go about to get that testing. And also, I say there's benefits and complaints to being, in the US healthcare system, but in a lot of ways, we're very fortunate to be able to try to mitigate the care that we provide to our patients, whereas colleagues in the UK and in Europe, they have certain criteria where they can only offer so much testing within the clinical world. But you are the consumer of your insurance, whether it's a Medicaid or a commercial. So
with being consumers of your insurance plan, you can't obtain your own approval for testing, but you can always communicate back with any insurance communication. So especially with COVID, we've seen delays in insurance. They still mail things, believe it or not, to our office. So that has to come to the main mail room, and then it goes and travels to the office, whereas you're going to get a direct communication, whether through email or other devices like your home address. And essentially, there's some key things if you are trying to speed the process along or to help with communication about a procedure, testing, an office visit. And a few things that would need to be communicated back to the team is an authorization number, the dates these are approved. Some are for 3 months, some are only for 30 days. And then the codes that are approved and who you spoke with. I will say, and we've all been there, that depending on who you talk with in insurance, that you may get a little bit of a different answer. And that could be that the person wasn't looking in the right portal, or they didn't understand your plan, or that this has already been tried before. So there are a lot of different barriers to insurance communication, but holding them to this and writing down who you spoke with is really helpful in the long run. And just thinking about the different codes that even go into these letters that you get and these EOBs. There's Cpt codes, which these are essentially the codes related to the testing, office visits, imaging studies that you're going to have done, procedures. And then there's ICD-10 codes. And these codes are essentially your diagnosis codes. So, mitochondrial disease is one of them. If you have seizures, they're listed separately. And then you also have NPI numbers. So these are particular for the physician or the billers for the visit. And I always, as Michael had said, fortunately, we are not headlong into the bills, and there is a team within our institution to work with. And you should always contact the number on the bill, whether from a hospital or lab. Your clinical team typically are not the ones negotiating. or speaking with insurance. But if you don't make headway, it's always good to just let them know so they can push it up the chain of command. If you reach out to them first, they might not be able to provide any additional insight until you talk with the lab to see, or the hospital, if there's any reduction in the bill. And then I also think, just as getting friends within the institution that you follow with, get someone in your insurance company too. There are individuals called case managers, so they can help you understand your plan, and they can even aid in auth and referrals. So it's great to have that direct contact line. We have patients sometimes that say, oh, I have a case manager. Here's their contact information that we can pass along to the billing individuals. And then same with knowing your rights. If something is denied, you have the right to appeal. You are able to appeal from a consumer standpoint, the denial. Just like with us, that's not always successful, but that is within your rights. And then also thinking about bills, I always think of, as you know, in rare disease, we do a lot of clinical and a lot of research testing. And clinical testing is a lot different, because I always think of that as you're going to be sending a test, you're guaranteed a report or some sort of document in hand for that service, and that would generate a bill. And so you or insurance or someone's paying for that service. Whereas research is different. Research is something that's done whether for an academic pursuit to better understand the disease, and that's being paid for by someone else outside of you all, not your insurance and not you. Usually that's funded by grants or hospital or other resources or advocacy groups like the UMDF, where you would not see a bill from that, which I think can be confusing, because just like at CHOP and other institutions, we do a lot on the same day. So understanding what is being done clinically, when would you expect results versus what's done on a research basis. And you know, the other support for medical bills, you know, institutions need to bill all patients the same, and you know, but working with the institution to figure out what they have to offer. I also think if you have an office that has a social worker, they are incredible resources to try to find out other things, like Michael was saying, charity care and other ways to mitigate the medical bill costs. And other things are, you know, just like at CHOP and other institutions, like we unfortunately can't help pay for the medical visit, because that's like soliciting business in that way. But fortunately, there are other ways to offset that. So let's say you have a $900 bill from a medical visit, but you also have a wheelchair you need to buy out of pocket. So that's also unfortunately probably just as expensive, if not more. There are ways that maybe you can mitigate where you could have the wheelchair get paid for by other charity care or other resources, and that would allow and free up funds to help pay for the medical bill. There are grants from institutions, something, you know, at CHOP, there's ones that have charity care. If you're admitted to the hospital for a prolonged time, they'll help pick up things like a mortgage or a car payment or other things where bills get piled up. And then also, as I was saying too, a lot of people need to travel for care to a Mito specialist. There are ways to help get travel assistance and costs, whether it's flight vouchers or hotel reductions or meals. I think there is tons of resources out there that, you know, I think people and individuals, finances and money are never anything anyone wants to talk about, but it's a huge burden that our patients and families can undergo. And to mitigate some of that cost, especially when there's so many resources. And I will say too, these resources are not for those in poverty. You know, they are available to anyone. And they kind of go through, each one may have different criteria, and some are income driven, but others are based on medical need. And then of course, there's additional resources at the UMDF to see if you or your family would be eligible for. And then I think in the end, you know, you're not alone. We're all trying to fight this journey, whether it's legislation. I'll share a brief thing that, you know, at CHOP recently, a big New Jersey Medicaid plan is no longer in network with us. And there's been a lot of advocacy group from the institution and the patient groups And, I think everyone wants everyone to get proper and equal care. And it's just one of these hurdles that we all have to navigate together with all these different insurance plans. And I'll end there.
Which is a great time for questions and answers from our panelists. If you have a question, please submit it in the Q&A and we'll try to get it answered for you. So hearing all of this and being a patient, I know these bills, sometimes you feel like you need, 3 people to look at it to make sure they're all correct and what you're supposed to pay. So Michael, I want to start with you. One of the things you said, and you did too, Colleen, is self-pay. So I want to talk a little bit about that. If you are self-pay, can you negotiate those costs? I mean, I hate to say this, but are you provided with a price list if you're confronted with something so you can see exactly what you're going to pay, and can you negotiate those?
So the answer is generally yes. And a lot of the business that we do for the clients I serve is we provide self-pay collections, patient billing. And there are generally 2 prongs to it. So one is a balance after insurance bill, and one is what we call true self-pay, where the patient has no insurance at all. So let's deal with the balance after insurance, because I think that's the more common. Okay. And the answer is depends on the policy of the institution, but generally there is some negotiation. However, it is usually in exchange for a prompt pay. So I talked about a payment plan over 24 months. You generally can't get a discount and be on a payment plan. If they're going to give you a discount, you have to pay it all at once. During tax time, this time of the year, January through May, many institutions run what we call in the business a tax settlement campaign, where they'll send letters knowing that you have your tax refund, so maybe you have some extra money, and it'll say, you owe us $100, pay us $80 today, and we'll forgive the other $20. As I said in my presentation, though, you cannot waive a deductible. You can only waive coinsurance. So that can get a little complicated in the beginning of the year when people have deductibles. But again, that's generally how it works.
Okay. Dr. Goldstein, I want to ask you this question. It came in before, submitted prior to the webcast. But for patients who are taken to an ER and they're in need of emergency care and IV fluids, how can a parent or a caregiver prepare in advance for this? So is there a way to classify a mitochondrial emergency similar to bringing a patient in who may be having a stroke?
Sure. So when we see patients, we give advice about when to seek emergency care. And many times that might have to do with calling your other specialists, such as your PCP or the child's pediatrician, especially to get advice about, if it's a common childhood illness like, diarrhea, dehydration, things like that. We will also, in many cases, also provide an emergency room letter. And many times, especially if my patient's living far away, that might not be my emergency room, right? So they're going to an outside emergency room. And what I can say is that I'm not then the emergency room doctor. And so my letter provides whatever guidance I can provide to that other physician. And I try to communicate the child's or the patient's diagnosis, what common problems might send them to the emergency room, how to triage them quickly, giving a little warning that this patient might look okay when they arrive, but they could actually get worse sitting out in the emergency room waiting room. And so to triage that patient quickly, to do some labs, to who to call, especially if there are caregivers that are very familiar with that patient's care, especially on staff at the hospital. I think a frequent frustration, though, is that many parents will come in later and say they didn't read your letter, or they read it and they ignored my suggestions. And, there are 2 things. One, again, I'm not an emergency room physician and I don't have control over that emergency room. I'm here giving my best advice to another physician, and then they need to use their own medical judgment. If it is something that we find that actually is not to the patient's advantage, we can do a few things. One is we can identify another hospital for that patient to use in an emergency. And then the second thing we can do is I can try to call that emergency room or speak to the emergency room director or have a parent follow up when it's not an emergency with that emergency room director, and really try to get some communication between the physicians that will be taking care of that patient and then the patient's needs. Another instance I will give is that many of our patients will seek emergency care if they are having a stroke-like episode to go in and get IV arginine. We've had a number of parents and patients go to that emergency room and arginine was not available. So that's something that they can do in follow-up, is call the emergency room director and say, I may be coming for IV arginine. Can you please make sure it's stocked so that I have that for my use? And so again, communication when in doubt is always really good, especially when it's not the actual heat of the moment emergency. It's easier to make those plans and communications ahead of time or afterwards with some points about what went wrong, how can we do better in the future?
Especially if you're going to be going back to that ER in the future.
Absolutely. And I will say that, you know, in general, like I'm a neurologist, so usually when my patients are having an emergency, it can be seizure related or stroke related. I don't recommend people drive for hours in the car when there's an emergency. The medical advice is to seek care at your local closest hospital. If you have 911 services, if it's an emergency, you need to utilize your 911 or ambulance services. Sometimes there's a bill for that. But the ambulance, if you call an emergency service, they have rules about, can they assess you and leave you at home? Do they have to bring you in? They usually, even if you say, please bring me to hospital A, they may say, sorry, we have to take you to hospital B. So there are a lot of things, again, that may be a little bit out of our control. And it's nice to flesh that out either ahead of time or after the fact to make the process better for future visits.
Colleen, I want to talk to you about diagnostic and treatment codes. So patients are billed on those codes. How do they know, with all of these codes and things, how do they know if they're being billed the right amount of money for the amount of time that was used by the physician or the facility?
Yeah, that's a great question. It in two parts. So one, if you think of time, that's usually the clinical time. So just like as Michael was saying, you could ask. Usually there's a number attached to it, whether it's 90 minutes or 60 minutes or prolonged, as you know, sometimes we're in the visits for quite a long time with complex patients. So physician, those codes are a little bit more clearer on the thing. The harder one is diagnostic and labs because they overlap with each other. So it's good to always ask for an itemized bill from the institution that can actually break down all of the charges, as opposed to trying to figure out the alphabet soup, and then you can know if anything was erroneously charged and communicate that back.
Michael, we know that this pandemic has caused a lot of financial stress on families. You know, we've got people not working or unable, their, you know, businesses shut down. And I've heard some things about medical appointments getting canceled because the patient or caregiver may be behind. Now, I know you said that the physician may not know the financial situation, but during this pandemic that we're in, and if that should happen, how are there ways that the patient can continue to get care?
So again, back to my thoughts during my portion, and as Dr. Goldstein just said, communication is key. And the other thing that she said, which I agree with, is thinking about things in advance of when they happen is much better than getting somewhere and trying to figure it out. So if you know, and again, the rules vary from state to state, but if you know you're going to go see Dr. Goldstein at CHOP and your insurance is either out of network or won't cover it, you can call their billing office and request, you know, again, we're getting away from the word charity care. We're calling it patient assistance now so that there isn't a negative stigma attached to it. But these programs are available for that purpose. And one of the things that economically for the hospitals, there are billions, maybe trillions of dollars a year that are for care provided by hospitals that are unreimbursed. And it's part of the mission of all of these institutions to care for humans and care for human life. It's in the motto of our company. And so again, I am, if they're going to not allow you to come because you have a significant balance, that will happen during scheduling. And you'll work it out during the scheduling process. It would be, in my experience and opinion, very rare for an institution to say, we're not going to see Michael Friedberg because he owes us $412 from the last 3 visits, and so we're not going to schedule him. There are also some requirements about continuity of care and when you start someplace, and there are certain responsibilities that practitioners have to their license and their oath. So that's my thoughts about that topic.
Well, I want to follow up with you on that. How often are, in your opinion, in your experience, how often are mistakes made on bills?
Colleen will laugh. Always? Again, with all good intentions, and as Colleen said, electronic medical records, the computerization of the billing process, the automation that now exists have reduced those errors. I mean, it used to be a bunch of people sitting in a room with typewriters typing in little boxes years and years ago. And so, again, and not only do the mistakes happen on the billing side, the mistakes happen on the insurance company side as well. Somebody's in network, they process them as out of network. They say a particular code isn't covered, and it may be covered. So, again, as Colleen and I both said, know your policy, know your rights. If you have employer-sponsored insurance, and I've done this a number of times over the years, and I'm having a problem with the insurance company, I've called the HR department and said, again, great example. We had an insurance, Zachary's on the ketogenic diet. He had a formula they had to take before someone from heaven invented Keto Cow. And we had to I was like a chemist in my kitchen, okay, putting these things together. And they came back to us and they said, okay, it's not covered. And this was in one of the questions. It's experimental. It's not proven. It's over the counter and non-prescription, right? And so we did the appeals. We wrote to the insurance company. And we even got on the phone with their medical director and Dr. Kerr, who is one of the experts in Zachary's disease, and explained, Zachary doesn't live without this stuff, right? And then we got an awesome letter from the insurance company that said, thank you for your discussion. We understand perfectly. It's still not covered. We're still not paying for it.
Well, one of the things that I know everyone knows that we advocate for is to have medical foods and supplements included in insurance coverage. We've been battling that for years and continue to battle it. And I know the Medical Nutritional Foods Act is being reintroduced into the Senate and into the House, and we will be seeking patient family support for that. But that doesn't solve the problem right this minute.
Correct.
When do you, and I'll toss this out to Molly, especially Dr. Goldstein, I know that, you provide you talk about a Mito cocktail. When do we see these things being covered on insurance policies? I mean, they're quite expensive. I know that patient families can spend anywhere from $400 to $1,500 a month. That's a huge amount of money. Do we think that
thank you, Cliff.
Sure.
So this is a huge issue, and we recognize this. And so on the one hand, we have the fact that these are not FDA approved therapies because there's never been a clinical trial where any of the vitamins went head to head with placebo. So they've never passed this randomized controlled trial. So the insurance companies can argue These are not FDA approved, right? The vitamins are not even FDA regulated, right? And so it becomes a little bit of a problem. However, we have much anecdotal and now preclinical and clinical evidence that the Mito cocktail, components in the Mito cocktail, in fact, are helpful for patients with mitochondrial disease. And there are certain supplements that you could handpick and say, I have a child with a documented cerebral folate deficiency based on spinal fluid results. The treatment for that is leucovorin or folinic acid. That's one of the ingredients that I'm putting in the Mito cocktail. We also now measure glutathione levels in blood, and we know one of the treatments for low glutathione levels is N-acetylcysteine. And so what we've done, because again, upfront, I think almost every insurance company will say, we don't pay for vitamins, we're done. And they walk away. And so, you know, one thing that we recognize is we do not have the staff and the manpower at CHOP to do a prior authorization for every single patient that we prescribe a Mito cocktail for. We also know that especially when it's children and even for some adults, when we're talking about 8 to 10 different vitamins and 60 pills a day, it's almost impossible to take all of that. So we have partnered with compounding pharmacies that are local to our area. And as Colleen mentioned, some are in other states. And our goals are to make it as easy as possible for the patients to take the Mito cocktail, for the pharmacy to have the language necessary to see if they can get the prior authorization through the insurance company, and then as scientists to provide as much literature and evidence that these are in fact medically necessary. And there is a new paper from Dr. Falk's group that provides a lot more updated evidence. Prior to last year, we were using a paper from 2009. And so there is now an updated vitamin paper from Dr. Barcelos, Dr. Shadyac, Dr. Ganetsky, and Dr. Falk from our group, which really does bring that closer to modern day medicine and justifying the use of the cocktail. So we are hoping that that will help. The other thing that I know, Cliff, you and I have talked about for probably 10 years now is that state by state, there's been a lot of bills that have been, you know, a lot, New England, right, where New England has been very active in trying to get the cocktails covered. So I think that we can do this from the medical side, from the pharmacy side, and one of the pharmacists is in fact amazing at going to bat for our patients in terms of getting that prior authorization and really lobbying for our patients. Patients and parents themselves can help lobby, you know, state to state. And when you do your advocacy work, and especially on the Hill, this is always a topic that comes up. So I think that hopefully, eventually, we will have enough from all of these angles to say this should be covered. These should be paid for because it's too expensive for people to pay out of pocket for this.
And the good news is, at least from what I'm seeing from the federal government, and you're right, Dr. Goldstein, it is a state by state because each state has its own insurance commissioner. But the good news from a federal aspect is that we are building more and more support from the House and Senate on these measures. So that's the good news. We just need to get it beyond the finish line and get it passed into law. And what I want to stay on this topic for one other question with you, Dr. Goldstein. So one of the things I saw today was in Pennsylvania, we have legislation that's coming up. And I'll try to explain this as succinctly as I can. So, and I know this has affected some patient families. So you prescribe a medication, the insurance company denies it. No, let me back up. You prescribe a medication. Medication doesn't work. So the doc has to prescribe another medication and that doesn't work. And it's like constantly prescribing these medications to get the right one because the insurance company won't pay for the more expensive one. How do you get around that?
Sometimes there is no go around. And sometimes the insurance company will say you can't have medicine X until you've tried medicine A and medicine B. Sometimes we'll write letters that say, well, I'm not using A for this particular reason. I recently had a patient that had been on a stable medication for literally 10 years. And all of a sudden and I was using it for seizures and spasticity. Her insurance company said, we're no longer paying for this. And here are the substitutes. And they were all antidepressives and anti-anxiety medicines. That's not why I was prescribing it. So all I had to do was say, I'm prescribing this for her epilepsy. what you're offering me as options are completely irrelevant. You need to pay for this medicine. And that worked. So sometimes, again, it's a matter of communication and making sure that the insurance company realizes the reason that that medication is prescribed. Again, a lot of the medicines we use have dual roles. Sometimes, the same medication can help with pain, headaches, neuropathy, seizures. So they just need to know what medication we're prescribing. But it is true that sometimes they say you need to fail medicine A and medicine B, and then we'll pay for medicine C.
I've personally been down that route, so it's very frustrating, and I can't imagine how frustrating it is for patient families. Michael, and I know we're getting short on time, so I do want to.
I just want to make a quick comment to
Sure.
what Dr. Goldstein was saying, just quickly. And I had this experience, and I want to do this very carefully. But we were getting some type of supplement or something, and we were going through a durable medical company that provides these things, and it wasn't covered, and we were having a hard time, and I ended up just calling the company directly or Googling it, and now we have Amazon, right? Take a look. It may be a less expensive, it's still not going to cost you nothing. And again, the carefulness I want to be with is you need to make sure your doctor is comfortable that whatever it is you're getting is equivalent, right? And not a lesser version. And I know with vitamins, sometimes there are brands that they recommend and don't recommend for various things. So that's where I want to be careful. But take a look and see what it is to get it commercially. Sometimes it may actually be a less expensive route.
Okay, and I want to ask you, if a provider makes a mistake, does the insurance carrier set a time limit on how long they have before they reimburse the provider?
So again, this was one of the questions that was proposed in advance. And so here's the short answer. There are two limits. There is a limit for a provider to file an initial claim with an insurance company, again, hospital or practitioner. And if they don't meet that deadline, then the claim will not be paid for timely filing. You may have heard that expression. Mm-hmm. In addition, the insurance company in most states has a period in which they are required to pay. And if they don't, they are required to pay the provider interest. That's not something we see very often. It's not really enforced. But yes, and if there is a mistake, as long as the initial bill was submitted timely, there are appeal limits, and again, they vary by insurance company and they vary by state to state, anywhere from as short as 45 days to as long as a year. But there is always an opportunity to correct a mistake. And you can always write an appeal letter that says it was unintentional and blah, blah, blah. And sometimes you get lucky and sometimes you don't.
Colleen, I'm going to wrap it up with you. So here's a question, because this was somebody asked me this. If you don't know the answer, maybe Michael does. But if you are behind on your medical bills, can they put that on your credit report and ruin you for other things?
So unfortunately, hospital bills do get submitted to creditors. And I think, and Michael, chime in with your company, but I know within our institution but there is ways, and that's key communication. So if there's questions about a bill, you can have that bill placed on hold. So while either things are being sorted out or something, and then it doesn't go to collections. But unfortunately, I don't know with all labs and diagnostics, but institutionals do submit that to creditors. And I've even seen it during COVID, unfortunately, too.
So the key word is dispute. If you call up and say, I am disputing this bill, it will typically be placed on hold and no action will be taken. There is a federal rule called 501R for nonprofit institutions, where they have certain limits on what they call extraordinary collection activities, ECAs. Credit reporting is one of them. And what we're doing now is we are credit reporting later in the process than we ever have. So those are the things that I would add.
That's good, because somebody said that the medical bill doesn't appear on your credit report. And I thought, well, I don't know about that, but I'm glad you answered that.
It's the provider's choice. It's probably 75-25 at this point, 75% choosing not to credit report and 25% choosing to credit report. And when we would credit report, it didn't necessarily improve payment. What generally would happen is somebody would go for a mortgage or a refinance, and they'd have a $50 bill that was in collections reported to the credit agency, and they'd call in a panic wanting to satisfy that bill so that they could get their mortgage through.
Well, panel, thank you very much. If we didn't get to your question, not to worry, you will get an answer offline. And thanks to my colleagues, Kara Stripmatter and Margaret Moore, whom many of you know, they're working in the background and making sure these webcasts happen for our patient families. Our panel, thank you so much for your time tonight and for your answers on Ask the Mito Doc. We really do appreciate it. And also, our patient families, thank you for the fantastic questions, both pre-webcast and while we were online here. Our next Ask the Mito Doc will come your way April 7th at 7:30. And we're going to talk about siblings and mitochondrial disease. So we hope you'll be able to join us. Until then, stay safe and be healthy. We'll see you next month.